Welcome to Roadmap to Residency, Evidence-Based Applications. So in this video, we will be discussing about antimicrobial agents and resistance. So these are the antibiotic classes. So the aminoglycosides, they all end with mycin, the cephalosporins, the ceftriaxone, the tetracycline, which end with cycline, the penicillin, which end with penicillin, sulfonamides, which starts with sulfur, like sulfamethoxazole, fluoroquinolones, like fluoxetine, macrolides, like thromycin, azithromycin, clarithromycin, carbapenem, like meropenem, imipenem, lincosamides, gain-mycin, and glycopeptides in mycin. Now, these are the mechanism of actions of different antibiotic classes. So the aminoglycosides, they inhibit the protein synthesis. The cephalosporins, they inhibit the cell wall synthesis. The tetracyclines, they inhibit the protein synthesis. The penicillins, they inhibit the cell wall synthesis again. The sulfonamides inhibit the folate synthesis. The fluoroquinolones inhibit the DNA replication. The macrolides inhibit again protein synthesis, carbapenems inhibit cell wall synthesis, lincosamides inhibit protein synthesis, and glycopeptides again they inhibit the cell wall synthesis. So you can see that most of these antibiotics they either they act on the protein synthesis or they act on the cell wall synthesis. And what is unique is the sulfonamides and fluoroquinolone. The sulfonamides acting on the folate synthesis and the fluoroquinolones acting on the DNA replication. Now we have discussed antibiotics in detail in our other videos. But as you can see, the different antibiotic classes, the examples, the organisms that they cover, the mechanism of action, and their uses. So we will go through each of them. So the aminoglycosides, example, streptomycin and gentamicin, they cover the gram-negative bacteria. Mechanism of action is inhibiting the protein synthesis, 30S. They are used in bacteremia and abdominal infections. The cephalosporins, example are ceftriaxone and cefepime. They cover the gram-positive as well as gram-negative, and they inhibit the cell wall synthesis. The uses are skin, urinary, and respiratory infections. Talking about tetracyclines, examples are tetracycline and doxycycline. They cover the gram-positive and gram-negative, and they inhibit the protein synthesis, and they can be used in Lyme disease, pelvic inflammatory disease, or sexually transmitted infections. Talking about penicillins like ampicillin and amoxicillin, they cover the gram-positive and gram-negative, and they inhibit the cell wall synthesis, and they are used for ENT, skin, and urinary infection. Talking about sulfonamides like sulfasalazine and sulfamethoxazole, they again cover the gram-positive and gram-negative both, and they inhibit the folate synthesis, and they can be used in UTIs, burns, and eye infection. Ciprofloxacin, levofloxacin, which are a class of fluoroquinolone, they inhibit the DNA replication, and they can be used for respiratory and urinary tract infections. Macrolides like azithromycin and erythromycin, they cover the gram-positive organisms, and they again inhibit the protein synthesis, that is 50S, and they can be used for pneumonia, sinus tract infections, and ENT infections. Talking about carbapenem like meropenem and artapenem, they cover both the gram-positive and gram-negative organisms, and they inhibit the cell wall synthesis. They can be used for urinary and abdominal infections. Talking about lincosamides like clindamycin, they can be used for skin, bone, and lung infections, and they inhibit the protein synthesis of ribosomal 50S. Glycopeptides like vancomycin, they cover the gram-positive organisms, and they are used for skin infection and bacterial endocarditis. Now, we have talked about the antibiotic resistance in our other videos, in other modules, but this is just a summary of that. The different mechanism of antibiotic resistance, we can see that the antibiotics, the microorganisms, they can outweigh the antibiotic via either efflux forms, that is, even if the drug gets in, the microorganism will just throw out the drugs via these efflux forms, or it can mutate at a certain level that there is decreased uptake of the drug, or it can just target the alteration, or it can just alter the binding site of the drug, or it can have an alternative enzyme. For example, if there is any drug that inhibits the enzyme of the bacteria, then the bacteria can just again make a new enzyme, or just can use an alternative enzyme for the process, or there can be some other inactivating enzymes in the microorganism which can just bind to the drug and make the drug inactive. So these are the different sorts of mechanism of antibiotic resistance. Now, talking about superbugs, so initially few bacteria have the antidote, that is antibiotic resistance. For example, this. the blue here, are antibiotic resistant. Now, only the bacteria that have the antidote will survive, okay, or only the antibiotic resistance bacteria will survive after we prescribe the antibiotic to the patient. Now, why the continuous antibiotic use? Soon the bacteria that survived will multiply and form an adapted bacterial population where everyone has the antibiotic resistance capacity. So if different antibiotics are indiscriminately used in human and animal health, discarded into the environment, soon several bacteria will suffer the same process described above, acquiring the antidote to two different antibiotics, and then they become superbugs. Here we have one question with us. So which of the following antibiotics will be most appropriate to add to the patient's regimen to provide synergistic activity against the suspected bacterial pathogens? A 42-year-old man with a history of chronic obstructive pulmonary disease presents to the emergency department with worsening dyspnea and productive cough for the past week. He reports increased sputum production that is purulent in nature. On physical examination, he is afebrile with a temperature of 101.3, tachypneic, and has bilateral coarse crackles and auscultation. Arterial blood gas analysis reveals respiratory acidosis with partial pressure of oxygen PaO2 of 55 and partial pressure of carbon dioxide PaCO2 of 55. A chest X-ray demonstrates bilateral infiltrates consistent with pneumonia. The patient is admitted to the hospital and is started on empiric antibiotics therapy with IV ceftriaxone and azithromycin. However, his clinical condition deteriorates over the next 24 hours and with persistent fever and worsening respiratory distress. Now, which of the following antibiotics will be most appropriate to add to the patient's regimen to provide the synergistic activity against the suspected bacterial pathogens? Amoxicillin, ciprofloxacin, vancomycin, gentamicin, or TMP-SMX? Now, gentamicin. The clinical scenario describes a 42-year-old man with COPD presenting with worsening dyspnea, productive cough, and febrile illness, consisting with severe community-acquired pneumonia. Now, the patient's worsening clinical condition, despite initial antibiotic therapy, suggests that there is inadequate coverage of the suspected bacterial pathogens. Aminoglycosides such as gentamicin are a class of antibiotics commonly used to treat severe bacterial infections, particularly those caused by aerobic gram-negative bacteria, including Pseudomonas aeruginosa and Enterobacteriaceae species. Aminoglycosides exert their bactericidal activity by inhibiting bacterial protein synthesis through binding to the 30S ribosomal subunit, leading to misreading of the mRNA template and production of non-functional or toxic proteins within the bacterial cell. Gentamicin in combination with beta-lactam antibiotics, example ceftriaxone, provides synergistic activity against a wide range of aerobic gram-negative bacteria, enhancing the overall efficacy of antibiotic therapy in severe infections. We have one more question with us. So which of the following is the most likely explanation for the patient's symptoms? A 68-year-old man with a history of chronic obstructive pulmonary disease presents to the emergency department with complaints of sudden onset severe pain and swelling in the right Achilles tendon. He reports that the pain started a few hours ago while he was walking up a flight of stairs. He denies any recent trauma or injury to the affected area, and the patient has been taking levofloxacin over the past week for an exacerbation of COPD. On examination, there is tenderness, warmth, and swelling over the right Achilles tendon with a palpable defect noted on palpation. Passive dorsiflexion of the foot elicits severe pain. Now the patient is having Achilles tendon rupture, and this is due to this medication. So the answer is D. So fluoroquinolone induced Achilles tendon rupture. So typically presents as a sudden onset pain and swelling in the affected tendon, often occurring without preceding trauma or injury. The rupture may be partial or complete and can be associated with palpable defect along the course of the tendon. These factors for fluoroquinolone-induced tendon disorders include advanced age, concomitant corticosteroid use, renal impairment, and previous tendon disorders. Thank you for watching. Keep studying.